Without too much delay, I'm just going to introduce Will. So Will is a clinical psychologist and professor of neurodevelopmental conditions at University College London, where he is joint director of the clinical psychology training course, which is the largest of its kind in Europe. His work aims to improve the recognition of autism, to develop new interventions to help autistic people, and he has a particular research interest in improving the identification and care of females on the autism spectrum who are currently at high risk of going unnoticed and unhelped by clinical and educational services. He also studies subdiagnostic autistic traits in non-clinical populations and the role these can play in the development of a range of common childhood, adolescent, and adult mental health problems. With colleagues at Great Ormond Street, he has developed and trialled interventions to help children with autism transition from primary to secondary school and to teach children about their autism diagnosis, with an emphasis on fostering their sense of self-worth and pride. And Will is going to be talking to us today about how mental health services for autistic people can be improved, with specific lessons that can be learned from the example of anorexia nervosa. So I'm going to pass over to Will, and just another reminder to please submit your questions for Will in the Q&A section, and we'll try and get to as many of those as we can afterwards.
Right. Well, many thanks for inviting me to give this talk at this wonderful Autistica event that's been going on this week, and thanks very much for the kind introduction as well. So, as you can see from the title of the talk, I'm going to be offering some of my thoughts on how mental health care for autistic people could be improved, and I'm aiming to do that by talking about a specific type of mental health difficulty and mental health service, which is for eating disorders, reporting on a study that myself and colleagues have been doing over the last few years on this topic. And the hope is that by identifying challenges and problems with eating disorder services, but also identifying potential solutions, that might generate some ideas that have a more general value in these kind of wider debates about how we can improve mental health services for autistic people. So, let's see if I can move the slide on. There we go. So here's the plan of the talk. I'm going to start off just talking about the current state of affairs for mental health services before going on to talk about autism and restrictive eating problems, in particular anorexia. And then finish with 6 suggestions that I hope that will generate towards building a mental health system for autistic people that is, to use that sort of piece of jargon, fit for purpose. In terms of what I'm going to be talking about, I suppose it's just worth mentioning that, obviously I will be talking about eating disorders, and I will sometimes be talking about the experiences of autistic women with eating disorders. So I sort of mention that by way of a trigger warning in case that might be upsetting for you. Okay, so to start with the basics, I suppose you might say, we know, of course, autism is not itself a mental health problem, but autistic people are at very high risk of developing mental health problems under current kind of cultural conditions. So, a real landmark study that raised awareness and highlighted that issue was by Emily Simonoff and colleagues, where they had a sample, a community sample of autistic young people, and found that 70% of them met criteria for at least one co-occurring mental health condition, and actually 40% met criteria for 2 or more. We also know that this is not just something limited to childhood, but this is actually something that goes across the lifespan of autistic people, and that was shown in this large meta-analysis that was published recently by a group of us, led by Meng-Xuan Lai and Caroline Cassie. And this just served to confirm, really, both the high rates of mental health difficulties experienced by autistic people across the lifespan, and also the kind of diversity of the problems that can occur. There's a wide range of mental health conditions that autistic people are at higher risk of experiencing. And again, this is an obvious point, perhaps barely needs making, but I think I will make it just on the basis of the evidence base, which, of course, these mental health problems are common and widespread amongst autistic people, and they really matter. They blight people's lives. They reduce quality of life and reduce levels of functioning. One mental health problem can often act as a risk factor for the development of further different mental health problems. And also, it seems very likely that the high levels of mental health difficulties experienced by autistic people likely contribute to the high mortality that that autistic people currently suffer. So we have very high levels of need, and yet, unfortunately, mental health services for autistic people on the whole, taken as a whole, I would argue, are currently not fit for purpose. And before I go on to kind of justify that slightly sweeping statement, I would like to make the point that I'm really not here to criticize individuals working in the mental health field. I've worked, as a clinical psychologist in mental health services myself. I know very well how dedicated, how passionate about their work, and how hardworking and skillful mental health workers are. So really, the problems that I'm going to be looking to highlight are really problems that occur because of the way the system is structured, the way it's funded, the way training is organised. I'm really not intending to criticise the individuals who work incredibly hard within that system. Okay, so how do I back up my statement that mental health services for autistic people are currently not fit for purpose? So we certainly see evidence that autistic people really struggle to access the mental health care they need. That was shown, for example, in this survey here in America, where 34% of autistic adults reported unmet mental health needs, which was twice as high as the rates in non-autistic people. And similarly, this survey from the UK by Lydia Jones and Laura Crane and others found a very similar picture. That whilst co-occurring mental health difficulties were really common and prominent difficulties of those seeking adult autism assessment, most had no idea how to seek help for these after their assessment. And one stat I've pulled out of that paper, 45% of participants wanted counselling after their autism assessment, and only 22% were offered it. We also find that when autistic people do use mental health services, we tend to see lower rates of satisfaction. And there are other sort of indicators that all is not working well. So, for example, there appear to be higher rates of drug prescriptions, including of multiple drug prescriptions, polypharmacy for autistic people. And also, and this has become an issue that's really actually quite high up on the NHS's agenda at the moment, there's an overrepresentation of autistic people in what you might call crisis care, in mental health inpatient units in the NHS. With the clear implication that something's not working if people are disproportionately likely to reach that point of crisis. And I've just included this sort of famous motto, for all physicians, but I think for all people in the helping sort of business. First, do no harm. It's worth remembering that when mental health services aren't right for autistic people, it's not just that autistic people are likely to miss out on the help they need, but there are risks that they can be actively hurt by the services they receive. And in fact, some of the data I'm going to show later do imply that is sometimes does go on inadvertently, not through anyone's bad intentions, but inadvertently in eating disorder services. So, okay, that's a bit of a grim picture in a sense. But I suppose the positive thing is that it feels to me that we are at a moment where there's a real awareness that things have to change. And there is also a growing, I think, kind of will to change things. The sense that things might actually start improving. For example, Autistica and James Lind Alliance did this really influential priority setting exercise with 1,000 members of the autism community, and the top priority that came out of that for autistic people and other members of the autism community is that research really needs to focus on improving mental health care for autistic people. We find no lesser organisation than the World Health Organization acknowledging this problem and making a resolution that that things need to change. And also, very promisingly, the NHS in its most recent long-term plan, and that's this document, this strategy document that the NHS puts out, kind of setting out the key strategic aims for the organisation for the next 10 years. Very prominent in that document is the acknowledgement that there needs to be an improvement in care for autistic people, including mental health care. So I think we're at a moment where there's lots and lots going on, researchers, policymakers, charities, clinicians, all sorts of people are kind of trying to improve things, and there's lots of conversations going on about that. So my hope today is that by talking about findings from our eating disorder work, I might be able to contribute a bit to that conversation that is hopefully going to reshape and improve mental health services for autistic people over the next 10 years or so. Okay, so let's move on now, if you like, to the main part of the talk, which is about autism and restrictive eating problems, lessons from the CDAF study. But before I go on to talk about a specific study, I want to give you a bit of background, tell you a bit in a way about the history of research into autism and restrictive eating problems. So what do I mean when I talk about restrictive eating problems, or indeed restrictive eating disorders? So fundamentally, we're talking about mental health conditions that the key feature of is people limiting their calorie intake, and perhaps also manipulating or controlling their calorie burning, their calorie usage, resulting in weight loss. And the archetypal restrictive eating disorder and the diagnosis that most people in this study I'm going to be talking about actually have been diagnosed with is anorexia nervosa. So this is diagnosed when a person becomes significantly underweight due to restricted eating. And crucially, it's defined as this weight loss behavior is designed as reflecting an intense fear of putting on weight and a distorted body image. So the ideal of anorexia is that the restrictive behaviors are driven by weight and shape concerns. Onset is typically in adolescence and early adulthood. It affects many more females than males, although there is some evidence for historical underdiagnosis of males, but nevertheless, it does affect more females than males. And again, whilst many people who've experienced anorexia recover and go on to live lives not dominated by an eating disorder, it is nevertheless quite a dangerous mental health condition with higher rates of mortality than most others. So it's a really serious thing that needs to be treated in a timely and effective manner. So that's anorexia, but the term restrictive eating disorders is actually slightly broader than that. So when I talk about restrictive eating disorders, and I talk about, for example, including women in our study who have a restrictive eating disorder, most of them will have anorexia nervosa, but we also included atypical anorexia, so people who have the fundamental characteristics, if you like, of anorexia, but don't quite meet the full criteria. And also, the term restrictive eating is used here to include the diagnosis of ARFID, which stands for Avoidant Restrictive Food Intake Disorder. Relatively new diagnosis, actually. And fundamentally what ARFID is when people are severely restricting food intake, but it's not driven by weight and shape concerns. Yeah, that's a kind of reasonable lay definition of ARFID. Okay, so again, giving you a bit of background, the first I know of a sort of proposed link between anorexia and autism appearing in the literature came from Chris Gillberg and colleagues in Sweden. And so certainly there was this paper in 1985 where Gillberg kind of remarked that in clinical practice he had noticed that he was working with some clients with anorexia who were actually undiagnosed autistic women. Eventually, Gillberg and his colleagues set about kind of testing out scientifically that idea that came from clinical observation in a study that's come to be known as the Gothenburg study. So this involved recruiting a cohort of 51 people with adolescent onset anorexia. And these were overwhelmingly women. So there were 49 women and two men. And they followed this cohort over time for many years, actually. And one of the things they did with this cohort, again, repeatedly, was to assess them for autism. And those assessments are summarized in this very useful paper by Vanessa Hook and colleagues here. And these are the basic findings. So each of these rows represents another assessment wave in the in the Gothenburg study. And whilst you can see the rates of estimated autism in this sample rather fluctuate over time, what they came to settle on was that about 25% of these, mainly women, diagnosed with anorexia nervosa actually were also autistic. So that was a phenomenally high estimate. You know, if you think what you would expect, how many autistic people you would expect to find in a group of 49, 51 women, it's many times higher than would be expected there. So this initial finding that about a quarter of women with eating disorders were autistic was initially greeted with a fair amount of skepticism. I think one reason for that was there were questions about the assessment methods used in the Gothenburg studies, and certainly in the earlier days, some of these were not quite optimal, although they greatly improved throughout the study. But I think the more fundamental critique of the kind of this apparent finding of very high rates of autism amongst people with anorexia nervosa was about the effects of starvation. So the point that critics made of these Gilbert studies was that starvation has a range of psychological effects, and these can include things like becoming less flexible in your behavior and thinking, having lower social motivation, processing social information differently. And so the idea is that the critics thought that what might be happening here is that actually in the Gothenburg studies, people were mislabeling the effects of starvation as being the characteristics of autism, and thereby inflating their estimates of how many autistic women there were in this sample of people with anorexia nervosa. So interestingly, there's been work done since trying to kind of get around that problem and trying to see, is there really a link between autism and anorexia, even if we manage to kind of, if you like, control for the effects of starvation. And generally, that literature has pretty strongly confirmed the original Gothenburg Gilbert findings. Yeah. So when Heather Westwood used really high quality assessment measures with a group of women who were receiving treatment for anorexia, she found again these similarly high rates of autism. Studies that have focused on historical report of autistic characteristics prior to the onset of any eating disorder and starvation have again tended to replicate the finding. And in the Gothenburg study itself, when I think almost the entire cohort were recovered and weight restored, so no longer experiencing starvation, they continue to observe that around 20–25% of people in the cohort were autistic. And again, importantly, Francesca Solmi, in her work, managed to measure autistic traits prospectively in childhood, and then see the extent to which they predicted later onset of anorexia-like behaviors, and again found this link between autistic traits in this case and anorexia behaviors. So the current strength of evidence at the moment does support the idea that 20–30% of women with anorexia nervosa are autistic, which I appreciate is a very high proportion, but those are what the numbers are coming back with. So that's the context for the study I'm now going to tell you a bit about. And it's called Towards a Successful Treatment of Anorexia Nervosa in Autistic Women. It's funded by Autistica and also with some additional funding from UCL and the University of Cardiff. And the aim of the study is fundamentally, as the title implies, to contribute to treatment for restrictive eating disorder or autistic women by better understanding barriers to service access, and better understanding what causes and maintains restrictive eating disorders in autistic women. And in order to try and achieve those aims, the project has two phases. There's phase one, which is complete, and that's a relatively large qualitative study with autistic women with experience of anorexia, parents, and also professionals with appropriate experience. And the idea of phase one was to get us an understanding of the actual experiences of autistic women as they use eating disorder services, and also to listen carefully to their stories about their development and the development of their eating disorders in order to generate ideas, hypotheses about what causes and maintains restrictive eating disorders in autistic women. And then phase 2 is about is a large quantitative study aimed at testing really the ideas generated in phase 1. So that's a typo there, I should say, testing ideas generated in phase 1. And I'm going to, we've just finished phase 2 and we're still analysing the data, but I am going to present some initial findings from that today. And I want to make clear that this is very much a team effort. So whilst I'm presenting these data were created and this work was done by a team of people who you can see here. And in particular, Yanina Brader and Charlie Babbs, who are doing their PhDs as part of this project and have done most of the work, so deserve much credit for that. Okay, so now I'm going to go on to talk about some of the things we've found, and particularly in relation to discoveries about where things are going a bit wrong in terms of eating disorder services and how they work for their autistic patients, in particular autistic women. So I'm going to draw on this paper initially, which was led by Charlie. It's about the service experiences of autistic women who've had eating disorders. It's the analysis that I'm going to be talking about is based on in-depth interviews with 15 autistic women with experience of anorexia, 12 parents, and also 11 healthcare professionals in eating disorder services. And Charlie and Yanina, in collaboration with others in the team, conducted a thematic analysis to understand these service user experiences. Okay, so the first barrier, I think, that really jumps out at us from these data is the underdiagnosis of autism. Yeah, so most participants in our QUAL study, 14 out of 15, were only diagnosed with autism after they were diagnosed with an eating disorder. So they presented to mental health services, they lived their adolescence without their autism having been recognised. And this is really borne out in our quantitative data as well. So for the 51 women in the quantitative study who we recruited, autistic women with formal diagnosis of autism with an eating disorder, the mean age, the average age of their eating disorder diagnosis was 19 years, and the average age of their autism diagnosis was 8 years later at 27 years. So that's a lot of time being an autistic person in environments that are unaccommodating and often downright unhelpful to you, and without the person themselves and the people around them knowing. And I think another thing that really comes out of our data here is that being autistic, but when it's unrecognized, really matters for clinical care. So, this comment here, I think, illustrates this all too graphically. When I was in hospital, I kept getting told off for walking on tiptoes and for fidgeting a lot. They thought I was doing these things to burn more calories, except I'd been doing them as long as I could remember. So this person's being actively criticized simply for expressing autistic characteristics because those characteristics are being misunderstood and misinterpreted. And again, you see some of the effects on sort of self-esteem and on people's ability to engage with treatment, to feel trusting of the treatment they're being offered. I felt very criticized. I was being very resistant, or labeled as being very resistant. I don't think they took into account how difficult I found it, seeing lots of different people. So the second barrier I want to talk about to good care that we found out about in eating disorder services concerns lack of knowledge in mental health services. And again, I really want to make a point here. I'm not criticizing the people who work in eating disorder services for that, because in a sense, why would they have specialist knowledge of autism? They work in an eating disorder service. They haven't received systematic training. The word autism doesn't even appear in NICE guidelines for eating disorders. So I'm really not criticizing people working in these services, but rather I'm suggesting that the system and sort of particularly training regimes need to change in this respect for mental health professionals. So in Charlie Babb et al.'s paper in 2021, there is evidence of low levels of knowledge about autism in many eating disorder services. And crucially, there's direct evidence that this impacts significantly upon treatment. This woman told us, I felt like they didn't care. I used to like to sit in the same seat just because I knew where it was. And every day a different staff member would go and sit there and they wouldn't understand why I was getting upset. So again, you can really see a lack of understanding of autism impacting on care there. We also see another element to this, and this was reported by a healthcare professional actually in our study. So they said, I think the coexistence of autism as well as the eating disorder is something that just makes some adults teams feel it's just too complicated. We just don't really want to know. And this is quite a common thing that comes up, is the idea that the lack of autism knowledge and confidence among some of these professionals can actually cause services to become actively exclusionary to autistic people. And I'm sure many of you would have come across instances where services said, I'm sorry, we can't see you in our mental health service because we don't have the skills and expertise to work with autistic people. So effectively, autistic people being excluded from the mental health services that they need. It's also worth noting that when people did have autism knowledge and were happy to act on that, it could make a real difference. So this woman told us, when I explained about needing the food separate, she's talking about the food on her plate, they were very good at accommodating that. And they would separate out the food and they didn't necessarily challenge that. They also gave me the opportunity to try it differently if I wanted to. And again, this healthcare professional shows a real understanding and willingness to make adaptations for autistic clients. Noise is something that has got to patients, and they found that really difficult. We made allowances in terms of music therapy taking place as far away from her as possible. Okay, so the third barrier I'm going to identify from our study is that standard eating disorder treatments just aren't always accessible to autistic people in the way that services are currently configured. And so the idea here is that there are barriers to assessment treatments that could potentially be effective for eating disorder. So one parent put it, rather well with this quote: "Our daughter has not been able to go through the sausage machine of evidence-based care. She keeps falling off the conveyor belt." And to give a bit more detail on that, so the sort of things we would come across. So, for example, this woman talks about CBT and how she felt that she didn't have some of the kind of foundational skills needed to access CBT, and she wasn't given help to develop those. And it doesn't sound like the CBT she was offered was adapted in any way to accommodate her particular pattern of skills and strengths and also difficulty. We heard a lot about groups. So, quite a lot of interventions in eating disorder services are delivered rather as groups, which can be challenging. This woman says they had other groups as well, one which was just a general talking group, which I found was really unhelpful because they had no structure to it. And then this other person said, I'm largely silent in any sort of group situation because I don't know what's expected of me. I'm worried of saying the wrong thing, or I worry about misinterpreting people. So again, this group kind of sounds like it was certainly not doing much good, and maybe even making things a bit worse just by stressing this person out. And again, it's really notable that these barriers can be overcomable if adjustments are made. This seems like a positive story that this woman's telling here. She says the adjustments they agreed were agreeing a time and day for key work sessions, giving me plenty of notice of change, and I could bring my soft duvet cover in. And that then meant that I was comfortable and I could sleep. So this will be in an inpatient unit. And it's just minor things like that that can make a really big difference. Yeah. So accessibility clearly an issue, but I think one that's definitely can be overcome with some knowledge and willingness. Okay, so this next point is not so much about access, or whether treatments are accessible. It's actually whether some of the treatments being offered are appropriate for autistic people. And I suppose what I'm going to argue here is that standard eating disorder treatment models, interventions, they don't always actually address the causes of eating disorders of autistic people. And I think that's a major barrier to services being more helpful to their autistic clients. So in order to kind of make this argument or put my point across here, I'm actually going to address a question that was core to this project I'm talking about, which is, are there autism-specific mechanisms that cause and maintain restrictive eating disorders? And sort of lurking around that, there's a subsidiary question, which is, and are these autism-specific mechanisms, are these not well addressed by current treatment approaches? So in order to tell you a bit about our answers to these questions, I'm now going to move on to talk about another paper that came out of phase 1 of our study, the qualitative phase of our study, which is this one. Again, it's effectively on the same sample as the paper I was talking about before. 15 autistic women, 12 parents, 16 healthcare professionals in eating disorder and autism services. And again, thematic analysis was conducted by Janina, led by Janina Breda with Charlie Babb and with others. And in this paper, we, based on careful qualitative interviews and analysis, we developed a kind of model of restrictive eating disorders of autistic women. And I suppose you could think of this as a set of hypotheses, really. It's a model that needs to be tested. And I want to tell you a bit about that model now. So what we concluded from this qualitative work, from listening very carefully to the experiences of autistic women and parents and healthcare professionals, was that really at the center of many of these women's eating disorders was sort of driven by very high levels of distress, of things like really high anxiety, sadness, sometimes anger, low self-esteem, very, very difficult emotional experiences that often felt overwhelming and perhaps even unbearable at times. And what many women told us was that the restrictive eating was essentially an attempt to deal with and cope with those high levels of the stress. So that, for some, that seemed to work through a kind of almost physiological process whereby starvation served to kind of dampen down and numb emotions and indeed sometimes sensory overload. And so people had learned that through restrictive eating, it was a way of kind of dampening down difficult feelings. And others would talk about how the kind of, by imposing on themselves almost mathematically driven rules about calorie consumption, calorie burning, that imposed some order, some predictability on a world that felt very chaotic and frightening, and that's how the restrictive eating could be calming. And I think what was really striking was how rarely the women in this study stated that their eating difficulties were driven by weight and shape concerns. And that's funny because they're all diagnosed with anorexia in this qualitative study. So by definition, they should all have weight and shape concerns, but we didn't find high levels of those in this sample. So these quotes give you a sense of how we arrived at these ideas. So what I wanted was to be able to restrict food and over-exercise without losing weight. So that's why it was so atypical. It was more like behaviors that I engaged with to feel calm, but would lead to catastrophic weight loss. And then a healthcare professional expressed a sort of similar view to this one. They said, when you unpick it, it's not driven the same way. It's not about body image. They couldn't care less what other people think about their body. So there's a clear idea coming out of this model that weight and shape concerns may be less implicated in the development and maintenance of restrictive eating disorders of autistic women compared to non-autistic women. Okay, so in this model, how do we understand these high levels of stress? Well, the thing that jumps out at you from the transcripts and from the interviews is that fundamentally, these high levels of the stress were driven by prolonged experiences of being autistic, almost always undiagnosed, in environments that were unsupportive, inappropriate for those people, and sometimes downright hostile. So experiences of bullying and peer rejection were common. Like I said, people living with unrecognized autism, so they're frequently being misunderstood and sometimes criticized just simply for being themselves. And women also spoke about having lived large parts of their lives with feeling this kind of obligation to mask and camouflage their autism. So, really, in this model, we understand the high levels of the stress very much within the sort of context that these autistic women live in and grew up in. And in a sense, you could put it in terms of there being a kind of a real mismatch between, on the one hand, the individual, their characteristics, including their autistic characteristics, and on the other hand, the environments that they were operating in, and the social environments. So, for example, this woman, clearly linked the kind of the stress of being a sort of unsupported autistic person to the development of eating problems. So the moment when I stopped eating at school was because there was a big canteen, lots of people, lots of social stuff going on, lots of noise. And then another person again talks about the damaging effects of their early years without a diagnosis. You constantly feel like you're failing. You constantly feel different. You think it's all your fault because you don't know there's something different about you. And so just the last part of the model I want to draw attention to kind of relates to the idea of like, okay, so people are experiencing high levels of the stress, but why is it maybe that they developed eating problems in response to that distress rather than another type of difficulty? And here, what we were told often by participants was that there were things about their autistic characteristics that made them more likely to have eating difficulties, particularly under conditions where they were being high distress due to not being treated well. And so, for example, people would sometimes talk about their kind of sensory experiences, particularly around food, as you can see from this quote here. And also another one that would come up both from autistic women as well as from, in this case, from a healthcare professional, was about differences in how some autistic women experience their internal sensations, and in particular some saying that they actually struggle to recognize when they're hungry, and that predisposed them to developing restrictive eating problems, because it almost made restrictive eating kind of more accessible to them, because they had this capacity to miss meals and not to actually really notice. Okay, so that's the model developed from our qualitative work. And I'm now going to briefly go on and share some initial findings from our quantitative study about kind of testing out some of these ideas I've just put forward to you, and really just fundamentally testing out this idea. Is it the case that there might be some autism specific mechanisms driving these eating disorders, and might that be a problem because the treatments these women are receiving are not autism specific and are not designed to address any autism specific sort of risk factors or difficulties that might be driving eating disorders? So, in order to tell you about those findings, I'm going to just quickly introduce you to our sample for the phase 2 of our study, the quantitative part. So we recruited 3 groups of people. We had a group of autistic women who didn't have an eating disorder, and in fact didn't have a history of eating disorder either. 48 of them, they're in this first column. We recruited a second group who were autistic women who were currently experiencing a restrictive eating disorder, so anorexia, autism, or ARFID. Anorexia, atypical anorexia, or ARFID. And then we had a third group of women who, again, are currently experiencing a restrictive eating disorder, but don't have an autism diagnosis. And we had 110 of those. And you can see that in some ways, these groups differed in slightly unpredictable ways. So actually our autism group were, the autism only group, were a bit older than the other two and had more likely to have been educated in university. And then there were other sort of more predictable ways, I guess, in which the groups differed. And in particular, of course, the autism group had a higher, on average, body mass index than the two groups who were recruited specifically because they're currently experiencing eating disorders. And again, just to give you a sense sort of clinically of these groups, so you can see here, the kind of predictable pattern of levels of autistic traits as measured by the RADS, which is this 14-item self-report measure that covers both kind of current and historical autistic characteristics. And so the two autism groups were similarly high on the RADS and were much higher than was scored in the eating disorders without autism group. Again, the two eating disorder groups had high levels of anxiety and depression than the autism group. And I think this last finding is quite interesting, actually, whereby the autism plus eating disorders group were distinguished from the other two groups by having particularly high levels of social anxiety. And so that implies that there's something particular about social anxiety that may well be implicated in the development of eating disorders of autistic women. And I think that maps on a bit to our idea that, sort of high distress and, high socially related distress, perhaps stemming from a history of really negative social experiences, may well be a really important driver of difficulties of autistic women. Specifically, I mean, eating difficulties. Okay, but what about this kind of central idea that came out of the phase 1 of our study, which was that the weight and shape concerns were less important in the development and maintenance of restrictive eating problems for autistic women compared to non-autistic women. And one of the ways we tested that out was by giving our participants a measure called the Eating Disorder Examination Questionnaire, the EDEQ, which is a widely used measure that specifically taps symptoms of eating disorder that are linked to weight and shape concerns. Yeah, so it's very much measuring weight and shape concern related eating disorder characteristics. And in line with our predictions, in our hypothesis, we did indeed find that the autistic women who had an eating disorder showed lower scores on the EDEQ than did non-autistic women with an eating disorder. So that was supportive of the idea that weight and shape concerns are less important or less prevalent in that group. It should be noted, however, that there were still reasonably high levels of weight and shape concerns in our autism plus eating disorders group. So I think it's important to realize that whilst it's likely that the weight and shape concerns play less of a role, they nevertheless are important in the experiences and eating disorders of some autistic women. So that needs to be recognized. And I suppose the other side to that is this question, do autistic women with eating disorders tend to have non-weight and shape drivers of their eating difficulties? Do they tend to have more kind of autism related factors that might be implicated, might be underpinning some of their eating difficulties? And I'm thinking of things like sensory processing differences or interoception, maybe difficulties sensing when you're hungry or when you're full, or particularly valuing predictability and disliking unpredictability, whether those sorts of characteristics might be playing into some of the eating difficulties that we saw in our sample of women with mostly diagnosed anorexia, but with more broadly with restricted eating difficulties. And we assessed that using a measure called the Swedish Eating Assessment for Autism Spectrum Disorders, the SWEA, which particularly measures kind of autism-related eating characteristics and eating difficulties. And the data were supportive of this idea, in that the SWEA scores were particularly high for our autism plus restrictive eating disorders group, much higher indeed than for the autism only group and for the REDS only. And I should have said these analyses were significant both when they were unadjusted, but also when we controlled for age and the differences in levels of anxiety, depression and social anxiety between our groups. Okay, so I'm moving towards the end here. So let me just summarize key points on mental health care for autistic people from the study of eating disorders. So I think the first point that I want to really draw out here that was just very, very prominent in our data is we need to avoid individualistic and decontextualized understanding of autistic mental health challenges. And that came through very clearly when we talked to autistic women and also to their parents. I think the other key barrier, underdiagnosis of autism, continues to be a major barrier to good mental health for autistic people. It increases the risk of developing mental health problems because it means autistic people end up in environments that aren't adapted to accommodate them. And it also decreases opportunities for accessible and effective care. Services are frequently inaccessible to autistic people. They often, again, not through any bad intention on people's part, but just often unwittingly present practical barriers to access. Maybe it might be around sensory elements of the environment, the way in which information is communicated, and so on. Some mental health environments, it seems, can also be overtly exclusionary to autistic people, saying, we just don't know how to work with autistic people, so we can't accept referrals. And many places are currently not able to adapt their treatment pathways to make them accessible. And I think, based on some of the evidence I've been sharing with you, I think it's probably likely, certainly in eating disorder, but probably in other areas as well, that we lack treatment pathways or treatment methods that address autism-specific causal and maintaining factors for mental health problems. Right, so I'm now going to finish off by offering a few of my thoughts on what could be done to address these sorts of barriers in mental health care. So I also want to make the point that when we're thinking about services and how they should be set up to help autistic mental health, it's worth stating that obviously prevention is better than treatment, and we should be thinking not just about addressing problems when they arise, but also preventing them or kind of nipping problems in the bud when they are still early and hopefully in a somewhat milder form. So the first point, which won't surprise you given what I've been talking about today, is that I think screening and assessment of autism is crucial to the prevention and treatment of mental health difficulties. And have a look at this graph here, which is from a paper by Basma Afagi. And what it shows is prevalence of autism as recorded, as indexed, if you like, by somebody having an autism diagnosis in their GP notes. So in a sense, this is about what proportion of the population have autism kind of recorded in their kind of primary care data. And you can see that it shows those prevalence statistics over time, from 2009 to 2016. And also, it shows the trends in those prevalence statistics broken down by different age bands. That's what the different color lines show. And so the first thing that this shows is that the prevalence of recorded GP diagnosis of autism is going up for some age groups, but not for others. And in particular, it's going up for younger people, but it's barely going up or it's flatlining for those over the age of 25. And I suppose the other take home from this to me is that the diagnosed rates of autism are just much, much higher amongst young people than they are amongst adults and older adults. And clearly the inference from that is that there is still a massive underdiagnosis problem of adults and including older adults. And so many of these undiagnosed autistic adults will be using mental health services. Many will need mental health services, won't have them. And so I think it's essential that if they are to be helped, I think in most cases, it will be helpful for their autism to be named and acknowledged. So we need particularly better coverage of adults and older adults. Now, I wonder if that's going to involve actually using a slightly different model to what we have now and moving some adult autism assessment out of specialist adult autism clinics and embedding assessment in those places where we tend to find undiagnosed autistic people. So that might be homelessness services, actually, but it might also be mental health services, eating disorder services, IAP services, OCD clinics, or at least I think that if we don't set up the skills within mental health services for good adult autism assessment, I think at least there needs to be closer partnership between specialist services and their local mental health services. And I know that happens in some parts of the world, and I think it's a really positive model. So, with post-diagnostic psychoeducation, with assessment and diagnosis must go psychoeducation. There's growing evidence that psychoeducation after diagnosis, especially when it really emphasizes strengths, a positive neurodiversity view of autism, can improve outcomes. And I wonder whether there's potential here to harness much more peer-to-peer support, creating networks, and also I think some potential for telehealth and kind of remote psychoeducation interventions, because they're more accessible and they're more scalable. You can deliver them to large numbers of people cheaply in a way that, for example, one-to-one or small group face-to-face psychoeducation won't always be possible for. Okay, number 3 is that environment is key. We need to get away from research that, and this, I hold my hands up. I need to do this as well, and this is not always easy to do, but it needs to be done. We need to get away from research that simply tries to link individual traits of the person to mental health risk, because by just locating it all in the person, you're just not telling the full story, so you're not going to fully understand the situation. So I think we need epidemiological work that focuses on the dynamic interaction of the person and their context over time. And similarly, we need interventions that improve person-environment fit and thereby improve mental health for autistic people. So the idea being that you can improve person-environment fit, not just by changing the person, but of course by changing the environment. And there are obviously interventions that do that, but I think we need more of them, and we need more of them to be formally manualized and tested so that they enter the evidence base. And I think examples of that were the Step A program that I was involved in, which was a manualized intervention for adapting schools. And that showed promising initial evidence that did reduce mental health problems of autistic kids if you adapted the school to fit them better. And also the LEANS project at Edinburgh by Sue Fletcher-Watson, Alyssa Alcorn and others, where again, this is a project that's about educating youngsters about neurodiversity and giving them more positive beliefs about neurodiversity, so that effectively you're creating a more tolerant and understanding social environment around autistic kids in schools. So yeah, we need, not just to be looking at the person sort of isolated as an individual, but thinking about ways in which they dynamically interact with their family, and are there opportunities for intervention there? Thinking about a community as an environmental kind of layer, that might involve schools, the workplace, social care, and also more broadly society. And I think that's where there is a real role for work that lots of people are doing at the moment, which is of sort of going out there and challenging negative views about autism and trying to change the conversation about autism. This is my view, but I think the step we need to take is specialist pathways, not specialist services. So I think it's unlikely that we're going to manage to set up a whole kind of parallel mental health system for autistic people. I think it's much more practical, and probably more desirable too, that what we actually do instead is to create well-evidenced, well-designed pathways within existing mental health services that are inclusive and effective for autistic people. So that can include the sort of basic measures to make services more autism friendly. And we see, really exciting innovations going on, for example, with the Peace Pathway at the Maudsley with Kate Chantura and her team. I think there's probably, or there's almost certainly a role for telehealth in making services more accessible. Although important to recognize, telehealth is not just the sort of magic bullet. Has to be used carefully and flexibly, and also potential for autism-specific treatment models. And I think in many ways, this next one is the one that could be done most quickly and could make a big difference. And I think that's about training for those not in autism specialist services. So that could include people who are key gatekeepers to autism services, people like GPs, teachers, those working in social care, but also those working in specialist mental health services. And I think if you work for the NHS, you'll have to do, as part of your induction, you'll have to do an information governance training. You'll have to do probably some equality and diversity training. Maybe what we need are well-designed online kind of autism trainings that are considered to be just obligatory for people working in NHS mental health services. And then finally, I think we need ongoing research on autism-specific mechanisms and that could yield autism-specific treatments. And again, I'm aware that this is going on in many places. Thinking of just off the top of my head, Jackie Rogers and her team in Newcastle, or Frankie Happe and Freya Rumble and Debbie Spain working on trauma, all sorts of areas where people are really beginning to think about not just having a kind of one-size-fits-all model for understanding the mental health of autistic people, but actually thinking carefully about what might be causing and maintaining these difficulties. So I'm going to finish there. Thanks for listening. There's also a poster as part of this science festival, which I'm told is poster number 14 from our group, which tells you a little bit more about our findings. But I'm now going to stop for questions. As I said, thank you for listening.
Brilliant. Thank you so much, Will. That's been a really fascinating presentation, really important subject and very clearly communicated and explained. We're getting lots of comments in of people appreciative of you doing this work and agreeing with you about how important this topic is, and we've already had loads of questions. But for those of you who want to ask questions, do still submit them via the Q&A. We're going to stay on a little bit past 11 o'clock so that we've got some time for questions for those of you who can stay. If you do have to go off, the questions will be available in the recording afterwards, so you will be able to come back and watch this section again. So I'll just jump straight into the questions if that's all right. Will, if you want to stop sharing your screen, it might be easier so that people can see you more clearly. So the first question that we've got is from Ginny, who's asked, why is there always such a focus on anorexia in autistic females as opposed to other eating disorders or other forms of disordered eating?
Yeah, I think it's a really, really important question. And I think the implication of it is that there needs to be more work outside of that, you know, in relation to bulimia, but also maybe to things like binge eating and things related to overweight. And also, you know, there needs to be much more awareness of ARFID, avoidant restrictive food intake disorder, which is, as I said, probably a much more appropriate label for many of the women in our studies, because it's a word for restrictive eating that isn't driven by weight and shape concerns. I mean, I don't actually know why there isn't more work in this area. I mean, I guess anorexia nervosa is the most researched eating disorder. It is a very urgent clinical problem. There's been a bit of a historical tendency for people to focus on it, but yeah, the point is well made, though, that we need to diversify the eating disorders that we're trying to understand here.
Okay, and the next question is quite related to that, actually. So it's adult eating disorders often state that they do not treat ARFID, or avoidant restricted food intake disorder, and that standard adult autism assessment doesn't include a screening for ARFID, even if it is felt that the person is highly likely to meet those criteria. So do you have any idea how adult services can be more able to recognize ARFID, more supportive of management and treatment in this situation, and is there a specific role for research in getting services to that place?
Yeah, I remember once doing a talk at a service, an eating disorder service, and their kind of manager made the point at the end that basically they are commissioned to treat anorexia, and so they, as you say, they actively tried to screen out people with ARFID, or, you know, things that didn't fit. So I guess part of the problem is, you know, is at the commissioning level, but I suppose a couple of things related to that. I think firstly, I was talking about the value of greater integration between autism specialist teams and sort of their local mental health services. I think that could be very helpful. And I also think that research could help, because if one can actually identify models, valid models of the eating difficulties of autistic people, and also identify kind of standardized ways of helping people, I think commissioners would be much more prepared to commission that. You know, if you could sort of show the way and show that this could be effective and cost effective, then I think that will become more commonly available. So I do think there's a real role for researchers to sort of lead the way there.
And the next question is from Hannah Hobson, who says, I wondered whether you're finding that autistic women tend to have lower, although still high, body image symptoms on standard measures of eating disorder symptoms. Could this mean that some women do not score above the clinical threshold on some standard measures of eating disorder symptoms, meaning that they're at a higher risk of having an eating disorder missed by clinicians who are trying to diagnose it?
Yeah, I think that's a really interesting and important point. Yeah, definitely. And again, I think this links to this other thing about, you know, eating disorder services having a sort of awareness of the kind of wider spectrum, if you like, of eating disorder presentations they might encounter. You know, in the, you know, approximately 25% of their clients who are autistic, and using measures, maybe like the SWIA, but also other things that aren't quite so tied in with weight and shape concerns. And I mean, I think surely the thing that we want to be moving to is a kind of, what people sometimes call precision medicine approach, which is that you don't just treat everybody as having an identical kind of condition with identical causes, but you actually have subgroups of people who have meaningfully distinct sort of causal and maintaining factors, and then you're able to have treatments that are appropriately targeted for those subgroups. And what we might find is that actually there are some non-autistic women who people are kind of assuming that weight and shape concerns are playing a really big role in their eating disorder, and actually maybe they also have factors much more prominently related, for example, to trying to regulate and cope with unbearable emotions, and they might also benefit from some of the sorts of treatments we're thinking of with respect to some autistic women.
Okay, the next question has actually been submitted by more than one person. So both Nicola Rathbone and Sue Fletcher-Watson have asked related questions about whether you, in the CDAF studies that you describe, consider gender dysphoria or people who had were people in the sample more or less likely to be non-binary, for example, or trans, or is that something that you measured in those studies?
Yeah. So the inclusion criteria obviously didn't exclude trans people, and so as I understand it, we don't have any trans women in the study, but we do have people who a sort of relatively small number of people who don't identify with a kind of the gender binary, and the trouble is, I think it was about 5 to 10%. I'd have to look that up, but it's an example. So I think that is a really important thing to look into, as indeed are the experiences of trans women, and the extent to which our findings are relevant there. The slight challenge is that we have quite small numbers in terms of doing statistical analysis, but that is a helpful suggestion, and it's something that we will have a think about as we're sort of really getting into the analysis of our data.
Sure, and maybe it's something to kind of dive into in qualitative analyses in the first instance. Yeah. So the next question you alluded to in your conclusion, but the question was submitted before you made the suggestion. So I'm going to pose it again in case you want to kind of elaborate. But the question comes from Nicholas Chown, who's asked, should there, in your opinion, be 3 support strands so that there are kind of mental health services, learning disability services, and then autism services, where the autism services are staffed by people who have an understanding of mental health and learning disability in the context of the needs of autistic people?
Yeah, it's a complex one, isn't it? I mean, it's kind of easy to say, oh, I think we need services to be better integrated. It's kind of harder to actually do that. I mean, one idea that I've heard people talk about that I believe is kind of on the table, if you like, and is being considered, including, I think, by the sort of policy work that people like Lorcan and Ed Smith are doing, is whether there's some sort of role for almost a kind of key worker or someone like that who if you are somebody who's autistic, you're kind of assigned to, and they're somebody who helps make decisions about whether you needed to be, if you like, escalated up a stepped care model. So if you need extra intensive support, and kind of helps people navigate through, be it the social care system, mental health system, autism specialist services. So maybe, something like that, it could be the kind of the glue, if you like, that does help to bring a bit more integration between these different strands of services.
Another question then from Sue Fletcher-Watson, who says, I agree with your call for better autism awareness for mental health professionals and also beyond that, so for social care and education, for example. But I worry that if we push for autism training, we will miss out on some other neurodivergent needs. So should we be calling for broader training on neurodiversity so that we can do better for people who have diagnoses like ADHD or developmental coordination disorder? So do we know, are their needs also being neglected in mental health settings?
Yeah, I think that's an excellent point from Sue there. I agree with it. I think there's a number of reasons. The reasons that Sue just gave, you know, the idea is that there are sort of a lot of commonalities, I think. There are differences as well, but a lot of commonalities in the experience of people who have a range of kind of neurodevelopmental differences and neurodiversity. And I think also another argument in favor of talking about neurodiversity rather than talking about ADHD or autism or developmental coordination disorder is that, of course, these things very often travel together anyway. And so I think that more integrated training would be more effective. Yeah, I agree.
Clarification question then from Jane Simpson, who said, I wonder if you could expand on what you mean by telehealth and how that might help in these type of services.
Sure. So actually, partly related to COVID, myself and colleagues have been doing quite a lot of thinking about telehealth. So what we're talking about really is the delivery of healthcare remotely using sort of technology. You know, and that could include, you know, I suppose at its most basic could be, you know, phone call or text messages, but might also include you know, Zoom calls and you know, other more sophisticated sort of means of remote interaction. And I think there's been this assumption that that telehealth, like, you know, autistic people will prefer telehealth. It will just make it so much easier for them to access services. That's not actually what we're finding in our initial studies on this. In that, you know, just like anybody else, autistic people's views on telehealth are quite diverse, and you know, some people like some aspects of it and some like others. But I do think if used sort of flexibly and creatively, I think it can just make services a bit more accessible. And so that's what I meant when I was talking about that.
Okay, and another clarification question then, this time from Nicola Rathbone, who's asked if the non-autistic group were screened for potentially unidentified autistic people in your studies. Yeah,
that's a really interesting point. And it reflects actually a debate that we're having in our team. So yeah, so basically the non-autism group were screened for autistic difficulties. And there is a subgroup of them who score really high on those screeners. Yeah. So, and it's exactly what we'd expect, isn't it? You know, given that, you know, Kate, you know, one of the main messages of the talk is that there are lots of people who are having restrictive eating disorder who are autistic and undiagnosed. And so actually, what is likely when we analyze these data, although I didn't do it today because it was kind of simpler to present it this way, is that although a priori we were going to analyze 3 groups, I think there's a strong justification for analyzing 4 groups and having splitting essentially the group who have restrictive eating disorders into those who don't show high levels of autistic traits and those who do, because then that becomes quite an interesting investigation into who are these people who have joined this study without an autism diagnosis but are scoring high on our measures of autism characteristics. And what I can tell you from initial analyses is that that subgroup look very similar to an autism group, an autism plus eating disorder group, which I think further just reinforces this idea of how many undiagnosed autistic women there still are being treated for eating disorders. So yeah, it's a really sort of insightful point there.
So I'll do 2 more questions and then we'll have to wrap up there, I'm afraid. So apologies to all of those whose questions we don't get to. I wish we had time for all of them. So this one is saying, this one has been submitted by Tim, who said, one barrier to accessing mental health services as an autistic person is funding. So my autism is not considered severe enough to require tailored support, despite my comorbidities of anxiety and depression. As a consequence, the treatment I'm offered is often limited to generic counselling or antidepressants like SSRIs. Anything else after that needs to be self-funded. So what is the role in research in changing these funding models?
Yeah, I'm sorry to hear that, Tim, as well. So I'll just remake a point I made earlier, which is I think that if researchers can demonstrate treatments and pathways that really do work for helping autistic people with their mental health problems, and what's more, if they can demonstrate that those are cost effective, i.e. that you kind of spend a bit of money on the treatment, but it kind of saves money in the long term, then I think they will be commissioned, is my sense. But until we have, you know, because we can't at the moment really offer those to commissioners, you know, so that work needs to be done first. And I also think, for example, you know, I'm wondering, Tim, if you've been sent to your local IAPT service, improving access to psychological therapy, which is this pretty low intensity intervention service for anxiety and depression using evidence-based treatments. And I think it's an essential piece of this jigsaw that we influence how IAPT works, because there will be lots and lots of autistic people trying to access IAPT, and the anecdotal evidence I hear is that it's often not very successful for them. So a pathway that involves screening and then adaptations to treatments, and possibly even kind of autism-specific models offered to that subgroup, I think would potentially help matters. And I'm sort of thinking of Elsa Russell's work on adapting CBT for depression. Those sorts of things are I think where we can improve services and change funding structures.
All right, and the last question has been submitted by Marilyn, but it reflects quite a few other questions that have come in on a similar topic. So Marilyn said, I'm a parent of an autistic adult male who for most of his adult life has had problems with eating. His intake of food is not sufficient to maintain a healthy weight. He lives independently and over the last couple of years has sought help, but essentially over different time periods has been sent to autism and ADHD adult social care services, and during the pandemic, during a particular difficult point, was referred again to the community mental health services. But across all of these different settings, it seems that he keeps being labelled with disordered eating rather than an eating disorder. And that label seems to keep meaning that the support that he gets, which is a couple of hours per week, which is not specific to helping him with his eating problems, mean that services feel that they're able to say, this isn't our problem because it's disordered eating and it's part of his autism. Do you think that there's anything in terms of service change in particular that would stop that from happening? And do you think kind of that there's anything that can be done, either to advice to give to people about how to better navigate services, or does it fall mostly on reorganizing services and the kind of training and the pathways that you mentioned earlier?
Yeah, interesting question. I mean, I'm going to speculate and say that it sounds like your son, or somebody in your son's position might meet criteria for ARFID, which is restrictive intake of food, but it's not, not driven by necessary desire to be thin. And I think that it's really important actually that ARFID is diagnosed more. So to avoid the fallacy that, oh, he's autistic, so it's inevitable that he'll have these serious eating problems, whereas actually once it gets labelled as ARFID, then it becomes a different entity that can be a target for treatment and intervention. But I suppose the other thing is that it's very, very early days in terms of developing treatments for ARFID. And unfortunately, most of the work that I know that's going on with this, and I may be wrong, there may be other stuff I don't know about, is quite focused on children and young people. So I do think that there needs to be more ARFID research, and it needs to not leave out the adults, because, and I suppose your question is really important because, of course, we've done a study on autistic women, and that's not because, I don't think it's important to study eating difficulties of autistic men. It's just that they're kind of somewhat rarer and it's harder to recruit autistic men. So we just focused on the women for kind of statistical reasons, in a sense, rather than just recruit a small group of men. But, in a sense, the model I put forward, which is this idea of, that sort of distress related to things like stigma and sort of lack of support is a big driver of eating difficulties. There's no reason why that should be gender specific. So, I do think there's an important question of where are the autistic men with eating problems, and where are they ending up, and are they getting help? And it sounds like, unfortunately, from the point of your son's experiences, that currently the services are just not configured to kind of fit those people.
All right, well, that just leads me to say thank you very much, Will. That's been an absolutely fascinating presentation. And thanks everyone for sending in all of those questions. They've been really, really interesting, and apologies to those whose questions we haven't got to. The video of this and all of the rest of our talks are going to be available on the Autistica YouTube in a couple of weeks' time. So if anyone has found this helpful and thinks others would benefit from listening to these talks, please do share the links widely. Do join us at 2 o'clock today if you're available for our session on inclusive environments. And don't forget to have a look at the poster session that Will mentioned previously in his talk. You'll find the link for that in the program as well. And thank you to our sponsors, Fujitsu, who've made it possible to bring this festival to you for free. And please do join the conversation on Twitter using our Autistica Festival hashtag. Thanks again, Will. We really appreciate the presentation.
Thank you very much for having me, and have a good rest of the day, everyone.